we talk about? What questions do you have? Yes.
So, I think this patient, we call her Margaret Mauer, I think that's her last name. She had a subdural, she fell back down the steps, her cat jumped out at her. I don't know if you can hear her. But anyway, she was given Keppra, and we were asking, okay, it wasn't right away, she got it towards the end of her stay with us.
Keppra?
Right.
After subdural?
Right. So
Alright.
we were like, okay, if she didn't have, was that just preventative? For
No.
the case?
Yeah, I mean, it could have been preventative. So, I guess, let me answer this question by asking, what's a seizure? And where do they originate?
So it is abnormal brain activity. Abnormal brain, electrical activity in the brain.
Yeah, it's pretty good. It says an abnormal electrical activity of the brain. And where does it originate from? In the brain.
Temporal area.
Yeah, it's one of the different regions, but in general. Can they originate from cerebellum? Can it? No, it can't. It can only come from the cortex. So seizures can only come from a cortex. It cannot come from any subcortical area or any non-cortical areas like brainstem, cerebellum, thalamus, basal ganglia. It can't come from that. It only comes from the cortex. Okay, cortex, as we have talked about before, is the outside of the brain, right? The top layer of the brain, or the rind, as you would call it. So that's where the seizure starts from. So where is subdural? Let me draw it out so you can get an idea of what I'm talking about. So I'm going to draw a coronal view. Oh, yeah, it's better. Yeah, side view. Okay. That's the brain stem, that's the brain. Yeah? So far so good? And this is the skull. And then this ends here, and then the spine around it goes around and so on and so forth. Okay. So that's the skull, that's the brain within it. So can somebody tell me what kind of bleeds you can get inside and outside? Starting from the very out, going to the very in.
Any kind of bleed? Any kind?
Any kind of bleed.
Subdural, epidural, subarachnoid,
Okay.
subdural.
Yeah. So let me just draw some layers inside here for a second. Alright. So this is the bone itself, right? The bone. That's the bone. Okay. On top of the bone is what? It's not a trick question. Skin. Scalp. Right. So there is a thin layer of connective tissue above the bone and below the skin. It's called galea. So there will be some galea on top of it. Galea. And then on top of the galea, you'll get the skin. Or the scalp, right? In this case, we'll call it the scalp. And then if you go below the bone, then you will get a dura underneath, right? Which is a thick layer. That's called the dura mater. And then underneath the dura mater is the arachnoid membrane. stuck right onto the brain is a very, very, very extremely thin layer. Anybody tell me what that layer is? Pia. Pia mater. Okay. So that's the pia mater. Okay. And then inside this thing are the ventricles. Okay, that's the ventricular system. Okay. So where can you bleed? Pretty much everywhere you can imagine you can bleed. Right? So let's just go from the out to in. You can get a scalp hematoma, right? Or you can have just laceration, cut your head open, right? And then you'll just bleed outside. Or if you don't bleed outside, then you bleed within the skin itself. That's the scalp hematoma, the goose-egg people get. Okay. You can have a bleeding underneath the galea, what's called a subgaleal bleeding. Not a big deal, it's no different than scalp hematoma. Then you can get bleeding between the bone and the dura mater, right? So it's above the dura. What kind of bleed would that be? Epidural, right? What epi means above. So epidural is above the dura. Then if you go underneath the dura, so between the dura and the arachnoid membrane, it's below the dura now. What kind of bleed would you get below the dura? Subdural bleed. Now you can get arachnoid and pia mater, right? So you can get bleeding below the arachnoid membrane as well, between the arachnoid and the pia. What is that called? Subarachnoid hemorrhage. You can get blood between the pia and the brain as well. That's called subpial hemorrhage, right? Which is extremely rare and is of no consequence. It doesn't really cause anything. Then you can get the bleeding in the tissue of the brain itself. That is known as? Infarct is ischemia, yeah. But the actual bleeding is in the parenchyma of the brain, the tissue of the brain itself. So that will be known as intraparenchymal hemorrhage. Okay, so you can get intraparenchymal, which is in the tissue of the brain, substance of the brain itself. And then you can get blood in the ventricle, which will be known as intraventricular hemorrhage. Fairly simple. Okay? The point being that you can get bleeding anywhere. You have to understand where the bleeding is and what the consequences would be. To come to your question, why did this lady with subdural hemorrhage get Keppra? That was the original question. Okay. So by the way, the reason what blood vessels bleed here are different for each kind. Okay? Subdural hemorrhage happens because of the bridging veins get sheared. There are veins going from the brain out to the dura, right? And those veins can break in a trauma, and you can get a subdural hemorrhage. So you can get subdural blood there. When there's blood, what the blood will do, it can't push outside, right? Because there's bone up top, so it can't push outwards. So it can only push one way, is on to the brain, right? So you can get a hematoma pushing on the brain. You can get hematoma pushing on the brain, putting pressure on the brain. Right? The brain so you will get, you see how the brain is now deformed, right? So it's putting pressure on the brain. Where do the seizures come from? Cortex. What is being deformed? The cortex. Exactly, right? The cortex is being deformed. So because of this phenomena, subdurals are the most epileptogenic bleeds that you can have. of all the bleeds that we mentioned, the subdural are the most epileptogenic, meaning that they cause the most amount of seizures. Okay. If you have a bleeding deep into the brain, will it cause seizures? Intraparenchymal? No. Why? Because it's not affecting the cortex of the brain at all. If you have bleeding in the ventricle, will it cause seizures? No. If you have bleeding in the brainstem, will it cause seizures? If you have bleeding in the cerebellum, will it cause seizures? No. They can't because it's not in the right place. It needs to be in the cortex to cause the seizures, or affecting the cortex somehow, right? So can subarachnoid blood cause seizures? Yes, because it is still above the cortex and it's putting pressure on the cortex. Right? So subarachnoid blood can cause seizures, but subarachnoid blood is not that much blood. There's a little amount of blood, so it doesn't put a whole lot of pressure on the cortex itself. It causes increased ICP globally, but it doesn't cause localized compression of the brain. Okay, so what you might ask, how in the world will a mechanical compression cause seizures? Right? So I'm pushing onto the, oh, you pull it up. That's cool. Although I think my picture is better. No? Okay, so how can a mechanical thing cause seizures? Or it can, even if it may not cause seizure, it will cause dysfunction of the cortex. Right? So cortex is not functioning properly. Right? So can mechanical compression affect electrical systems? Can you give me an example of mechanical compression causing electrical dysfunction or electrical activity?
Wouldn't the pressure itself?
Yeah, but why? I mean, if you have a let's say a cable running from the outlet to your whatever fan or something, right? Will you press on the wire? Will it cause any change?
No, it has to be like severed or.
Yeah, right. Something has to be done. So this is a different kind of phenomena. This is called piezoelectric phenomena. You have seen the cords in your watches, that responds to the electrical charge. So when you give it an electrical charge, the crystal expands. Okay, it expands and contracts with the cycling current. Similarly, if you take that quartz and you put mechanical pressure on it, it will generate an electrical current. Right. Thus proving that mechanical compression will cause dysfunction of the electrical signal. And that's what happens here, is that the mechanical compression of the cortex causes dysfunction. The neurons aren't able to perform the way they're supposed to perform. So it can take two forms. It can take the form of hyperactivity, which is seizures. So cortex is hyperactive and it just discharges uncontrollably and causes seizures. Or it doesn't discharge enough, right? So there is depression of cortical activity. It's suppressed, the cortical activity is suppressed. So now you can't do the activity that you want to do. So that looks like a stroke. So people look like they're having a stroke, but it's not a stroke. We had a couple of gentlemen, like within the last month or two, in the ICU with subdurals, who, weren't doing so well, and we kept scanning. They had a mental evacuation. We scanned their heads. There were no strokes, nothing. But they still couldn't move one side of the body, or were weak on one side of the body. You start anti-epileptics, in a couple of days they improve. Because what anti-epileptic is supposed to do is supposed to stabilize the membranes. Right? Stabilizes the membrane, therefore it improves the electrical conductivity. So they improve. So to answer your question, why was this reading on it? So prophylactic Keppra usage for subdural is about 7 days. Somebody comes in with subdural hemorrhage, and if you want to prevent seizures in them, and it's a reasonable idea because, as I said, subdural is the highest or most epileptogenic kind of a bleed. So if you want to use it prophylactically just to prevent seizures for 7 days, it's not a lifelong thing. But if you're treating the cortical dysfunction, then that could be a little bit longer because you're treating something, not preventing something. Does that answer your question? Yes. Okay. So I can't speak to exactly why she was, because I don't know if she had any seizures or not, or whether she had stroke-like symptoms or not?
Yeah, she was, her main thing was the dizziness she was having. And she was vomiting. It had well, she didn't have any, you know, any seizure activity as far as, other than vomiting and nausea.
Yeah, okay. Sounds good. All right, I guess you're done with that question. Any other questions?
So the case,
Case.
they put you on blast, girlfriend.
It was not on me. Do you remember?
They pulled him out
We
later.
did? Okay.
Yeah, tell me about the case.
We had a patient, he had a thrombectomy done at Northwestern.
Okay.
He had a few strokes. He was on medication for it and he kept stroking. He came in here because he had another stroke. They were small strokes, but they couldn't figure out
Okay.
why he kept stroking.
We're gonna pull up the case. Okay, so what medication was he on?
I think originally he was on aspirin and Plavix, and then he stroked again, and then they switched him to Eliquis. But I
And
might
he
have them
stroked.
flip-flopped.
Okay. Did we find out what the etiology of the stroke was? Do you have any carotid disease, any heart
So-
conditions?
He had, oh, go ahead.
So Yagan and I looked at this case. First, I'm mad because he went to Dyer, and they flew him to Northwestern instead of bringing him here, and he was having a large vessel occlusion back in May. But they ended up doing, they removed the clot, okay, he was fine, but he had residual, so he came in to our ED and he had aphasia, which was from before, it was residual, so there was no stroke alert ever called, but he was admitted to the neuro IMC for a workup. The problem is that when they do a workup on these patients, if they don't know the etiology, then they will do, that's why they do Dopplers, that's why they do the 3D echo. Well, they did one with bubble study, but we looked at it, and then we asked the wheel about it today, because there was no information in the actual result that there was any shunt, like, you know, usually they'll say shunt present or whatever. So we sent him home, not figuring out what exactly happened and why he keeps having these strokes. And yes, he was on medication, but he is now scheduled at Northwestern to have a PFO closure on in July. Yeah. So I feel like I'm upset about
61.
Yeah.
61?
Yep.
Okay. I'm gonna pull up the image. So the question is, why is he having stroke?
It was because of PFO. That's what I think.
They did do the whole blood workup for the dyscrasias, they were all negative. The protein C, S, antiphospholipid, all of it. They did that at Northwestern.
Not here.
Here.
Okay, so I guess that we're gonna go on many different directions on this case.
Okay.
But one question is,
So you want to see the images you said? I'm sorry.
what in the world is a PFO, and how would that cause a stroke? Anybody care to answer that?
Not you, Yagata. Not Steph, not Dan.
He's the first person.
Nobody want you to take a stab?
Like a non-medical easy way to explain it, he's just got a valve or an opening that's not closing all the way in his heart,
Boom.
and the clots are flying up to his head and causing a stroke.
Say that one more time.
So he's got an opening or a valve that's not closing all the way in his heart, that's causing clots
of a
to
valve?
go up.
No, there's no valve involved here.
Just an opening. The patent foramen, oval.
Yeah. I have no idea what those words mean. Somebody else explain that to me.
It's the. I can't, when I say this,
No?
when you guys have to.
Okay, we'll put the MRI. MRI. Hey, can anybody draw the circulation, just a sketch of circulation, or where the blood comes out of, from the heart and how it gets back to the heart? Come on, guys.
Don't be
You know
scared.
this.
Come
not harsh, come on.
You have a marker?
Yes, a whole bunch.
Thank you.
You want to do this?
That's not it.
That hard.
Do you want both of them done or just one?
I think it's good.
July 31st. Saturday. In like 16 days. July 31st? What day? It was a rain.
2015, it will be Friday.
Aww, I know.
It won't rain. If it does, it's good.
I mean, I'm fine with it does. I just gotta know, do I need to order some umbrellas or not?
Is it outside?
Yeah. In Nashville. Only my parents live there, everyone else is
Okay.
coming from out of state. There.
Okay. So then,
Yeah.
go down here.
It goes up. You gotta know where it's going.
That's okay, man, take it one step at a time.
Okay.
Let's just start, just draw a heart.
Okay.
That's his heart.
This is my heart.
Okay. No, it's good, it's good. So where is the blood coming out of in the heart?
Out?
Into?
Out of.
You mean in?
No,
He means out.
Out.
out of the
That's how
heart,
you're
where is
gonna
the
draw
blood
it?
coming from?
Your left lung ventricle.
Left ventricle, so draw an aorta for me. Out of the left ventricle. It doesn't have to be anatomically correct, just do it schematics. Okay, I like it. All right, write an aorta next to it, please. Okay, you got it. Now, where does the blood go from here?
Looks like it's the body. Like
Rest of the body. All right, so just you can draw another box down below and just write body on it. Okay, sounds good, looks good. Okay, now where does it go from the body?
Circles back up, like.
Yeah, to what?
The inferior vena cava.
And if you're vena cava, then what?
Back.
You're on the right track, dude. Okay, so it's just going up, right? So going up on inferior vena cava, it joins with the superior vena cava, right? And that junction is called sinoatrial junction, okay? Or cavoatrial junction rather. Okay, so now it's going to enter into the heart, right? Which portion of the heart will it enter? You drew the chambers correctly. So which chamber is it coming back into?
The right atrium.
Right atrium. So just draw a little vena cava here and draw an arrow that blood's getting into it. Okay, that's good. And if you wouldn't mind, just connect the loop here.
Okay.
No, you got it. Just draw a line. You got it. Okay. Okay. So we know that coming out of the left ventricle into the aorta, circles the body, comes into the vena cava, into the right atrium. Okay. So now what happens from the right atrium?
All right.
What's your name?
I'm Justin.
You're not Justin.
Sorry.
Justin.
It goes to the right ventricle.
Okay, right ventricle. So you have the arrow correct. Okay. So then what happens from the right ventricle? Where does it go from the right ventricle?
The pulmonary.
Pulmonary what? Artery or vein?
Vein.
It's always very simple. Anything coming out of the heart is an artery. Anything coming into the heart is a vein. So is it coming out of the heart or into the heart from the ventricle?
Into the heart.
Out of the heart.
Out of the heart, I'm sorry.
Alright, it's coming out of the heart into the lungs. Right? So here, use the equipment.
Thank you.
Okay. Now draw a tube out here. Label it pulmonary artery.
Like this.
Yeah. Pulmonary artery. You got it. Okay. Now where does it go from there? What does the P stand for?
Pulmonary
So where do you think it's going?
to lungs.
To lungs. So if you want to draw a box and write lungs on it. Okay. Now where it's gonna go from the lungs?
Back to the left atrium.
Left atrium. And what conduit, what is gonna take the blood away from the lungs into the heart? You already do pulmonary artery, so what's remaining?
Pulmonary veins.
Pulmonary vein, so you draw the tube there,
Like this, is that okay? Or
just
you
a
want
tube, just like this one, like a tube. Exactly, you got it. Okay, so that's pulmonary vein. That's it, now it's going back into the left ventricle, now it's going to go to the aorta, through the body, go into the right atrium to right ventricle to pulmonary artery, pulmonary to lungs, back to the pulmonary veins, down to the left ventricle, out again. Keeps on and on and on. Clear? Alright. Where in the world is this damn PFO?
It's, I kind of do my heart kind of janky, but it's
That's okay.
in here, like,
Between what? Between one and one? You're kind of pointing in the middle, I have no idea what you're doing.
Between the upper chambers.
Between the upper chambers. Right.
Sorry.
So, which are the
the right atrium, the left atrium.
the right atrium and the left atrium? Alright. So, you're gonna just do the color and draw a little hole inside. So, which I guess I'll give just a rest here. So,
Good job, Justin.
Very good, yes. Very nice.
if you have, you know, the atrium on the top chamber, right? There are two septums, or septi, in the middle. There is a septum primum and septum secundum, or second septum, okay? They are septum that is which combined together, they're known as intra-atrial septum, or interatrial septum, I should say. Right between the atrium, there's a septum, pretty simple. As a child, the circulation is different, all right? Because remember, when you're a fetus, you are not breathing. Your lungs, meaning the child's lung, the fetus's lung, is not functioning, all right? It's still developing, they're not taking on air because it's surrounded by amniotic fluid, right? So the mom's blood is what's oxygenated blood, and that sustains the fetus, right? So what happens in the heart is that there's an open hole. The blood comes from the vena cava, comes to the right atrium. It has no need to go to the lungs. It doesn't need to go to the lungs because there is no oxygenation happening. So what it does, there is a hole, it shunts from the right atrium directly to the left atrium, to the left ventricle, out into the body. Comes back right to the right atrium, to the left atrium, to the left ventricle, and out. The right ventricle and the whole pulmonary system is circumvented. Yeah? Okay. So you have a hole here. All right, so there are two layers here. There's a hole in there as a fetus, but when you are born, with the first breath, there's a change in pressure. Right? Intrathoracic pressure changes in the baby, and the heart pressure changes in the baby. And what that change in pressure does, it actually seals this thing here, right? Which pressures do you think are higher? The right atrial pressure or the left atrial pressure? Right, what would you think, right?
It should be more blood coming in from the body.
So the amount of blood flowing through the body is the same. No, it's the same. Whether it's in the right atrium or the left atrium, it's the Bernoulli's principle. The amount of flow has to remain the same. Okay. So flow is not in the consideration. But it's higher on the left atrium because guess what? There's a small engine underneath, right? There's a ventricle that pumps the blood, right? When it comes to the vena cava, there is no pump in between. Right? All there is this resistance in between, which is the body. But when it comes to the right ventricle, it's very, very low pressure. In fact, that's the lowest point, that lowest pressure point in the body. Right? Also known as the CVP, or the central venous pressure. Right? The central venous pressure is you measured in the right atrium, and that's the lowest. Right? After that, the pressure starts increasing. Point being, pressure is higher in the left atrium compared to the right atrium. Good?
Mm-hmm.
So if there is a flap, I'm going to draw a little funny flap here. So this is the second primum, and there's a secundum on top of it like this. Okay? This is the right, this is the left. Okay? This here is patent foramen ovale. Okay? So this usually, well, number one, in 75% of the people, this fuses completely after birth. In 25% of the people, 1 in 4, it remains open. Okay, it remains open, but there is a second layer covering it. Remember, this is the primum septum primum. This is the septum secundum, right? So there's a flap that closes it down. So left atrial pressure is higher than the right atrial pressure. The pressure pushes it down. All right, and usually it's not open. Usually it remains closed. Okay, so no big deal. So no big deal. Now you can have a defect in the septum secundum as well. Okay, so now you have both layers damaged, the primum and the secundum, and now you have a hole which is open all the time. That's called an atrial septal defect. Okay, it's not a PFO, it's an atrial septal defect, which is open all the time. We won't talk about ASD right now, but in PFO, what must happen for a clot to pass through are two things. One, the hole has to be large enough for a clot to pass through, because many a times they're just pinhole holes, right? It's a very teeny little dot of a hole. It's not really large enough for the clot to pass through. In other cases, it's very large and the clot will pass through. The second thing that has to happen is that the PFO has to open when the clot comes in, because, as I mentioned, the second layer closes the hole up. So this PFO has to somehow open to cause the clot to pass through. Does that make sense? Right. So what will make this hole open up? As I already mentioned, the left atrial pressure is higher than the right atrial pressure. It's pushing the flap down. So in order for the hole to open, you have to reverse this process. You following it so far? Mm-hmm. I'm sorry you can't see it because I'm standing in your way here. But it has to open. The right atrial pressure has to increase compared to the left atrial pressure. Right? And that happens when we do Valsalva maneuver, when you bear down. The right atrial pressure increases compared to the left atrial pressure. And that's why when we do the bubble injection, we ask them to do Valsalva, because that's what it does. Increases the right atrial pressure temporarily compared to the left atrial. So if there was a PFO, it will open up during Valsalva. Make sense? Now, not every PFO, as I mentioned, needs to be closed. Okay. So people who have strokes due to a PFO. Okay. So PFO, we talked about PFO. So question I originally asked is, how in the world would PFO cause a stroke? Okay. So 3 things need to happen for a PFO to be responsible for a stroke. Number 1, there has to be a clot somewhere. Right? Where would the clot be? In the legs or arms or something. Okay. What happens generally when you don't have a PFO? Right? Justin drew this awesome picture here of vena cava coming in. Right? What happens to the clot? Let's say you have a DVT. This is the leg part here. All right. You have a DVT. The clot gets dislodged. Where will it travel?
Lungs.
Why?
It's a circulation.
Yeah. So it will go from IVC to the cable atrial junction, into the right atrium to the right ventricle to the pulmonary artery, and then into the lungs. That's what the clot will just end up. Why would it end up in the clot? Why would it not go through the lungs? Hello? Yes, ma'am. We can discontinue that. No, it's one of the, let me go to that. Hey Dan, can you answer this?
Yep.
We don't need Depakote on that lady, the Damiano.
No, it was probably for headache. Hello?
Okay, so where were we?
Hello?
Why would it go to the lungs and get stuck there? Why wouldn't it just go through the lungs and come to the other side?
Pressure.
No, not pressure this time, no. Because what happens to the blood vessels in the lungs? They get really small. They get really small. It's like a sieve, right? It's like a sieve. So all this clot comes in. There's nothing to stop it from getting here because it's a huge, chunk of clot and the blood vessel is big. Comes to the right atrium. There's nothing to stop it there. It comes to the right ventricle. There's nothing to stop it there. Comes into the pulmonary artery. There's nothing to stop it there. It's going through and through. Or it's a huge highway for it. Comes to the lungs and the vessel gets small. It gets stuck there. Has no other place to go. Okay, so it goes to the lung and gets stuck. So if the clot always goes from this to the lungs all the time, how in the world is it getting to the brain? Because it's supposed to get stuck in the lungs. How in the world is it getting to the brain?
Shunting.
Shunting. Expound please. What do you mean by shunting?
So it's kind of bypassing the normal circulation of the heart.
Correct. How?
Through the PFO, and so instead of going, I guess, where the PFO is, it would shunt from right atrium to left.
Bingo. Because there's a PFO. Right? So if you happen to have, so I had a patient, was a few years ago. His story was that he got off a long flight, like 6-7 hour flight. All right, walks off the plane. He wants to use the washroom. He goes to the bathroom at the airport, and he's sitting down in the toilet, straining and bearing down. Has a stroke, keels over onto his right side or something, and is brought to the hospital. What do you think happened there? He vagal. That's a great answer. He could have just vagal, right? But he was plegic. He was hemiplegic. Maybe. You guys are Sherlock, not me. So what happened? What do you think happened there?
I think he had a clot that formed in his leg on the plane.
Yes.
I
Yes, he had a clot form on the plane because he was a long 6-7 hour flight. Then what happened?
Then it went through the circle of heart here, so popped
Yeah.
into the PFO.
What does him having to sit on the toilet have to do with it?
He vagal.
Because he was
You already
popping.
changed
Vagal, no, not vagal.
Change of pressure.
Change of
Valsalva.
Change of pressure. Change of pressure, right? The intrathoracic pressure increased, therefore the right atrial pressure increased, therefore opening up the PFO, therefore shunting the clot across the heart. So there's an intracardiac shunt. Who said shunt? Somebody said shunt from.
So even if it was originally closed, like for years, you can open it back up?
Yeah, so he probably was opening it up all the time. It's just that he didn't have a clot to shunt across, right? He could have shunted, you could have opened up that PFO the day before, the week before, the month before. It didn't really matter because there was no clot. But now there is a clot. So the clot went across, went from the right atrium to the left atrium, from left atrium to the left ventricle, out to the aorta, and up to the brain, right? So the brain is only 5% of the mass of the body, but it takes about 25 to 30% of the blood supply, right? So it punches way above its weight when it comes to blood supply, right? So when so let me just draw an arch here real quick so you guys get an understanding of what I'm talking about. So this is the heart. the arch. Right, this is the right subclavian artery. This is the right carotid, common carotid artery. This is the left common carotid artery. This is the left subclavian artery. And vertebrals are coming off of it like this. Okay? So it's kind of poor drawing, but you get the idea. So, right vertebral artery is coming off of it, right common carotid coming off of it, left common carotid coming off of it, left vertebral coming off of it. The four vessels which are supplying the brain are the first shot for that clot as soon as it comes out of the heart. It comes out of the heart, this clot, tiny little clot, it shoots out of the heart and going up. Where is it more likely to end up? In the brain. It doesn't always end up in the brain, I'll tell you that. We have seen clots in the arm that they threw from the heart, get stuck in the arm, get stuck in the leg. I've once seen a bowel infarction due to AFib as well. When the clot gets shot from the heart, goes down the aorta, goes into the superior or the inferior mesenteric artery, gets occluded, and then necroses the piece of bowel. Right? So you can have that, but that's very rare. Right? First shot that this clot gets is go to the brain. Because it's the first vessels which come off the aorta, right? And second, because the flow is so much higher to the organ of the brain than the organ of anything else. As I said, it's 25 to 30% of the blood is just taken up by the brain, even though it's such a small weight contributor to the body. Okay, so PFO goes and this happens also. I don't know the particulars of this case enough to tell you whether this PFO was responsible or not. But to answer your question more directly, why is this guy having a stroke? New strokes. I'm not certain that this guy did have another stroke. Okay. I'm not sure how the radiologist read it, but I'll show you what we do see here. Okay. What is this? Well, I guess we won't go into MRI. Have you never talked about MRI, right? The physics of MRI. Then I won't get into it. This is known as FLAIR sequence. FLAIR stands for Fluid Attenuated Inversion and Recovery. FLAIR, FLAIR. What FLAIR can tell you is, what strokes this patient has had, ever. 2 weeks ago, 2 years ago, 20 years ago, whatever. Okay. And you can see there's a signal change, a clear signal change in the posterior parietal region. Posterior parietal region. So this is, posterior temporal, posterior temporal. This is the temporal lobe right there. Okay, that's the temporal lobe, you can see this. And there's a stroke back here. Everybody sees that? Additionally, there's a stroke here. Why is it not going? Okay. Come on. Why is your computer so slow?
I don't know, because it's on our Wi-Fi, it's not probably on definite.
Okay. I don't know if you guys can see it from there or not. There's a difference in signal. There's a signal difference here versus there. Can you guys see that? Yeah, I don't think you can close it enough. I mean, it's already closed.
Yeah, I thought it
Maybe
was.
cut the lights out. Is it any better? I guess you guys can see. If you want to see it, you can come up and look at this computer here. This actually shows much better. But there is a signal change here as compared to here. It's always, whenever you look at the pictures, look at symmetric. Okay, compare the two sides. Okay, so you can see it here, you don't see it there. You can see it here, you don't see it here. Meaning there's something wrong. There's something different about this side versus that side. So he has a stroke here. He has a small stroke there. I bet you this guy had Wernicke's aphasia. Why? Because that's where the stroke is. The stroke is right over the Wernicke's region, Wernicke's area, right? So did he have aphasia?
Mhm.
Yeah, he probably did have aphasia because
Mhm.
the stroke is right there.
Mhm.
The stroke is right there, right? You probably wouldn't have had much motor symptoms, because I don't see any stroke in the motor areas at all. So he's not going to have much, right? So he had a clot, no doubt, thrown, and I'll tell you, looking at this, I'll tell you that I bet you he had a clot in his M1, his MCA M1 segment. And that's when they did the thrombectomy. And so now this area has a small infarct, because this is where the I'm just using words which you're not going to understand. So let me just draw it. How are we doing on time? Good on time?
Yeah, 20 minutes you got.
Okay. Okay. So the brain, the ICA goes up like this. And I'm drawing like a very schematic view of it, so not drawing it, perfectly how it is anatomically. But this is ICA. This is ACA. ICA, internal carotid artery. ACA, anterior cerebral artery, and MCA, middle cerebral artery. Middle cerebral artery then bifurcates into two. Usually two branches, superior, inferior, anterior, posterior, however you want to call it. Okay. So there are some other vessels which come from here. They're tiny vessels, like this. And they go deep into the substance of the brain. Okay, they perforate the brain. So if you look at the actual brain, you'll see little tiny holes in the brain. So there's a perforation in the brain. So these are called the perforator vessels, or perforating vessels. Okay. So these perforating vessels. One thing that's peculiar about these perforating vessels, and these are isolated territories, isolated vascular territories, meaning that if you block up one of these blood vessels, there is no other blood vessel coming to its rescue. So whatever tissue this blood vessel supplied is gone. Whatever, white matter, gray matter, nuclei, whatever it supplied, it's gone. That's infarcted. Okay? So what happens if there's a clot here? All right, there's a clot that's sitting here. Okay? There is no blood flow going this way, right? There is no blood flow going this way, right? Because blood comes up, it gets blocked by this clot. It's not going anywhere, right? So this part of the brain is also affected, right? It's not getting any blood. Let me just draw some brain here. This is the brain. So this portion of the brain is not getting blood because this is clotted out. But this portion is not getting blood either because there's no blood going past. But what this part of the brain has advantage of is that it has collateral supply. So these vessels like this come on top like this and supply these branches. All right? So these are collaterals, right? And because they run in the, by the way, in the blood vessels in the brain run in the arachnoid space. Remember arachnoid space we just talked about? So they run between the pia mater and the arachnoid membrane. That's where the blood vessels run, right? Both of these membranes combined, and they're thin membranes. Remember, arachnoid and the pia are very thin membranes. Dura is a thick membrane. So because the blood vessels run between the pia mater and the arachnoid, the thin membranes, it has a particular name. They're called leptomeningeal collaterals. Leptomeningeal. Meningeal collaterals. Okay. Lepto means thin. Okay. Thin meningeal collaterals. Okay. The dura mater is called known as pachymeninges. Okay. Pachy, like thick. Like pachyderm, like a rhinoceros or an elephant. Pachyderm, thick skin. Right? So that's pachymeningeal. This is leptomeningeal. Right? So this part of the brain, even though it's not getting any blood supply, this has a leg up because it's getting supply from the leptomeningeal collaterals. So you won't kill all of this brain. But this part of the brain you can't kill very quickly because these are isolated blood vessels. It doesn't have any collaterals coming in. Okay. So I can bet you a bag of chips and a Coke that this guy had a clot here, somewhere here. Okay. Therefore he had a stroke in this area. And the Northwestern guys were able to successfully pull the clot out, but a clot probably broke loose, a tiny clot broke loose, and went to the inferior division, in the temporal branch of the inferior division, and caused a stroke there. Right? And that's exactly what we see here. Is we see a stroke in here. You can see a stroke here, and you can see a stroke, yeah, here, right? And you see a stroke there, right? This is leptomeningeal, sorry, this is the lenticular striate. I won't go into it why these are called lenticular striate, but these are called lenticular striate vessels. Lenticular striate. And there's a reason why they're called it. I won't get into it. But these are lenticular striate vessels. They supply the basal ganglia. Okay? And lo and behold, there is a stroke in the basal ganglia from the lenticular striate blockage. And there's a stroke here. The only way you can explain both of these if there's a clot in the M1. If there's a clot in the M1, it will block off these blood vessels and will cause strokes here as well. Make sense? Okay, so that's a pretty typical pattern that we see in M1 occlusions is a stroke like this. So one thing for certain that he has, I still owe you an answer as to whether he had a new stroke or not. And I'll show you that I don't think he had a new stroke. Because see where the stroke is here in the basal ganglia, right? That's the stroke right there. I'll show you, I'll put them side by side. Has anybody looked at this, the images, or just everybody's going off the radiology's read? I'm going to say radiology read, yeah? But nobody has looked at it. That's okay, no big deal.
We need to do a class on imaging.
I have a class paper, didn't I do that once?
No, we did not, nobody else did.
Downstairs we did, remember?
Oh, what is that?
Okay, you have a crazy computer. I'm not doing anything.
Look, hold on. Here. That sucks.
Okay, anyways, the point I'm trying to make is that there's an arrow pointed by the radiologist on a teeny little dot of a signal change on DWI, and they're calling it a stroke, a new stroke. It's not a new stroke in my opinion, because it is exactly next to the basal ganglia lesion that we saw. Exactly next to it. Okay? So I think that's what's called a T2 shine through. Okay? I have to go over MRI for you to understand what I'm talking about. But it's called a T2 shine through. So what we are seeing here is a T2 shine through and not a new stroke. So if he came in with new symptoms, what he had was recrudescence of old symptoms. All right? Because there was something else wrong with them. Maybe he had an infection, maybe his electrolytes were off, maybe his sugars were off, whatever the case may be.
So is a T2 flare a new stroke?
No. If you want to look at the new stroke, It must be bright on DWI. So I'll draw a little table here, a little cheat sheet for you guys to. Okay. So we're going to do DWI, ADC, and flare. Okay. All right. By the way, all of these are T2 sequences. Okay, all of these are T2 sequences. DWI stands for diffusion weighted imaging. ADC stands for apparent diffusion coefficient. And flare stands for fluid attenuated inversion recovery. When we talk about MRI, we can explain why they're called that and what happens with them and so on and so forth. Anywho, if you want to look, if it's bright on DWI, and if it's dark on ADC, and it's ISO intense, meaning there's not really any signal change, that's an acute stroke. Okay? Now, if you have a chronic stroke, it would be ISO intense on DWI, ISO intense on ADC, and bright on flare. That's what chronic stroke. That what you were seeing there was a chronic stroke. It was just bright on flare. Right? But if you look at ADC and DWI, you won't see it because it's ISO intense on both. Okay? And then you have T2 shine through. So you have it bright on DWI, ISO intense on ADC, and bright on flare. So if you want to look at whether the stroke is whether number one is in a stroke or not, you go to DWI. And you look if it's bright or not. If it's bright, okay, now it got your attention. Okay. Then you would immediately go to ADC and see if it's dark on ADC or not. And if it's dark, then it's a stroke. If it's not dark, it's most likely not a stroke. Okay, I'm going to stop here because then I can go on and we'll just take you down a rabbit hole. So we'll just stop there. But this is a good cheat sheet, if you will, if you want to look at whether it's an acute stroke or not. Number one, is it a stroke? Second, is it an acute stroke? Okay. You cannot have a stroke without this being bright and this being dark. Okay. We have another 5 minutes. Any other questions you guys have?
Okay.
Yes,
I
ma'am.
have a question. So as far as that case, specifically, his was caused by the clot that got through.
Yeah, again, I don't really know. So I'll tell you that the cardiologists will tell you, though, it's a PFO, it's a PFO. But if you look at the Stroke Association guidelines, you have to go through so many hoops to say that this is not. So you're only allowed to close the PFO if you can't find any other etiology. Okay, so I don't know whether he had the full workup or not. But there are multiple things that you need to do to prove that you have not found any other cause, and therefore it is due to a PFO. Even the evaluation of PFO is quite technical. You have to make sure that the PFO is large enough, it's not a pinhole PFO, and it has appropriate shunting, right? Which cycle is it shunting through? Because most of the time it will only shunt in a systole. But if you have a large PFO, it will shunt even in the diastole, because over time what has happened is that RA pressures have increased. If a PFO continues to stay open, what happens every time the left atrium pumps, it will shunt. I'm just going to draw a simple box here, okay? This is the left atrium and right atrium, okay? Let's puncture, let's poke a hole inside, and there's a hole in there, permanent hole, okay? Every time because remember, the both atria squeeze at the same time. Okay, so as soon as the both atria squeeze at the same time, where is the pressure lowest? Let me ask you this first. Where is the pressure? In the right. It's the lowest. So where will the blood go? From right to left or left to right? Left to right, from high pressure to low pressure, right? So the pressure goes into the right atrium. Okay, no big deal. So blood goes here, most of the blood goes down to the left ventricle, some of the blood goes to the right atrium, it goes back to the right ventricle, shunts to the pulmonary artery, pulmonary vein comes back, and it just keeps going. But what would happen over time? This right atrium says, well, dude, you keep dumping your blood into me all the time. Every time we pump, you dump all this blood into me. So it becomes stronger over time to handle that extra pressure. And over time, the right atrial pressure starts increasing as well, all right? And there's a reversal that happens. I think it's called Eisenmenger syndrome or something like that, where there's the right atrial pressures are higher now than the left atrial pressure. So now the shunt is reversed. Shunt is reversed, all right? So you can get a reversal of the shunt from the right atrium to the left atrium. So in that instance, you will see the shunt even in diastole. Diastole, even within in diastole, you will see a shunt go from right to the left. Make sense?
Mhm.
So why do you think that PFO was missed? I mean, if it was big enough.
I'm not sure it
I
was
thought so,
missed.
too. I thought, wasn't it?
Was it missed?
That's why you feel like.
Yeah, we didn't find it.
No, it
I
wasn't.
mean, it wasn't
done.
It wasn't documented at all on our, when he was here.
Did we do,
It said with bubble,
That's what the
Bubble.
yes, no, we did it with bubble and there was
we
no,
didn't see that.
Valsalva?
right. So I don't think that's just a whole, I don't even know if they did the actual bubble.
Yeah, so if you didn't do bubble, you wouldn't see it.
But
Because
it
there's
was
no way of
ordered as
knowing.
that though.
I understand, but if it's not done with bubble, you wouldn't see it.
Right.
Exactly.
So if you want to see a PFO without bubble, you have to do a TEE to look at the structure of the heart. The only way to not the only way, but the best way to look at the PFO on TTE is do with bubble.
Mhm.
That's why it's part of the stroke order set.
Yeah.
Right? We don't even bother ordering without bubble. We always order with the bubble. Because why bother?
Mhm.
So this is Buchanan, this is her, our, the 6th of July, and this was her previous on the 29th of May.
One other reason, just to kind of close it down, and I think we'll just, after this next piece, I'm going to talk about this thing and then we'll finish it there. So, I mean, 61 is an old enough guy, right? So he could have, the question is, why did he have a stroke? I don't know. What, could it be a PFO? Yeah, it could be a PFO. I don't know. But he could have many other things that could have caused a stroke, right? Could it be a paroxysmal AFib? Yeah. Paroxysmal AFib as a cause of stroke is 10 times, maybe 20, 30 times more common than PFO as being a risk of stroke, right? So we were taught in med school, when you hear hooves, think horses, not zebras, right? If you're sitting on, I don't know, ground or someplace, you hear hooves coming past you. What would you think? You think it's a horse coming at your way or a zebra coming your way? A horse, because they're so much more common.
Oh. See, where are you going with this?
But you get it now.
I got it now.
Right? So when you get a stroke from the heart, why in the world would you think that it's a PFO? When the
Yeah.
paroxysmal AFib is so much more common. And if you don't think 61-year-old people can get AFibs, we have a 54-year-old right now who has AFib. For the last 2 years she has had AFib. Snezana Demjanovic. Right? So she has a AFib for a while. Young people get AFib too. My point being that. Okay, so AFib is, paroxysmal AFib is one of those things. The other part is that people can often get hypercoagulable state due to occult malignancy. Right? And sometimes the first manifestation of that occult malignancy is a stroke. Sometimes the manifestation of occult malignancy is a DVT. Right? Because you can have a very tiny cancer somewhere in the body, but that makes your blood hypercoagulable, and that can cause a stroke. So if you want to check for hypercoagulable workup, right? So if you think it is in a young patient, let's say young patient without any PFO, no PFO, you have done the proper echocardiogram and you have proven that there is no PFO, right? Then you need to do an arterial side workup. The things that cause arterial clots are different than things that cause venous clots. Okay? The arterial clots, let me.
It's 105.
Okay. And if people want to leave, please do. I don't let me keep you back. I know you guys have work to do and so on. So, arterial side, arterial hypercoag, coag, and venous hypercoag. Okay. Now, things that are causing venous clots don't usually cause, or much less likely to cause arterial side clots. Okay. What kind of things can cause venous clots? Factor V Leiden deficiency, right. Antithrombin 3 mutations, protein C and S deficiency,
That's what they did.
protein C and S deficiency, MTFHR. And so on. So there are a few other things that can cause. Okay, so that causes venous side clot. So if you are going to have positive any of this stuff, then you must prove to me the patient has a PFO. Because these things will cause clots on the vein. And if you have a venous clot, it's not going to the brain unless you have a PFO. Because otherwise it will just go to the lungs and cause a PE. Make sense? Mm-hmm. This, on the other hand, can cause direct clots on the arterial side and does not need to be in the vein, therefore then coming to the heart. It will cause directly on the arterial side. It will bypass the heart and lungs completely. Am I making sense to you guys? Yeah. Okay. So these are the three main ones that we check, and you can check other ones. And these are all happen to be antibodies. Okay. So there is lupus anticoagulant antibody. Lupus anticoagulant. Right, and then anti-cardiolipin antibody. Lipin antibody. And beta-2 and glycoprotein antibody. Right. These together combined are known as antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. Okay? So if you're looking for arterial side clots, you got to check for these two. If you're looking for venous side clots, you got to look for these. Arterial side can cause venous clots, but venous side issues can seldom will cause arterial clots. Okay? So I don't know if this guy had this done or not. I don't know if he had the hypercoagulable workup done or not. Maybe he did, maybe he did not. I have no idea. Okay? So just because some dude has a PFO doesn't necessarily mean you should close it. Okay? Do we have it up and running now?
Mm-hmm. That's the left, and it's current. The other one is
Yeah,
from
flare
May.
open or UI? Okay. You see this here? Is this which line, which two lines you think this is?
Right.
Bright. So it could either be an acute stroke or a T2 shine stroke. Yeah?
Yep.
Either of those two lines. It can't be the chronic stroke. All right. So this is now ADC. Same location here, same location there.
Dark.
What do you think that is? Dark. So what do you think that is?
It's
It's an
an acute stroke.
acute stroke.
So I have a question. We had a young lady, and I don't know if you were here, as Dr. Chen. She was 24, had a stroke. Why did we jump to an echo or a TEE rather than doing an echo?
Very good question. So because we think that, number one, so a woman who's 24 years old, what are the chances of having an AFib?
Low.
Very, very low. What are the chances that she has a structural heart problem? High.
Mm-hmm.
If you want to look at structure of the heart, you need? You got it. So we don't even bother, that you're that young, don't even bother with the TTE. Because see, the TTE is a good study for a general survey, but it doesn't increase your confidence too much. So even if you did the TTE, then you would still ask the cardiologist to do the TEE. Why do two? Just get to the chase, just cut to the chase and get the TEE. Make sense? Okay. I think that will wrap this up. All right. Thank you guys, thanks for coming.
Thank you.